I think the hour has struck, so we will begin. It's a pleasure to welcome everyone here for our Department of Surgery University rounds. And we also have many guests here from the Department of Anesthesia and Pain Medicine. Thank you, Bev. And so welcome to everyone. I think that's a testament to the great broad interest of this topic and speaker for all of us who share in perioperative management, preparation, and postoperative care. We will have an introduction from Paul Karanicholas of our guest speaker. But before that, I would like to begin by advancing the slide. There we go. So I'll start by acknowledging on all our behalf that the University of Toronto sits on land that was for thousands of years stewarded by many different communities of Indigenous peoples, including but not limited to the Mississaugas of the Credit, the Haudenosaunee, the Wendat, Huron, and the Anishinaabe. We acknowledge their ongoing participation in our community of scholars and learners, and we seek to do better in our relationships with them and with the land that they have stewarded in the future. So next on the program, we're going to have Michael Failings, our Vice Chair of Research, come and talk a little bit about Ben Alman, who has joined us in Toronto for this very auspicious occasion and lecture in his name. Michael, please.
Thank you, Professor Swallow, and greetings to the audience here. We've actually got an excellent audience, which I think is a testament to the excellence of our invited speaker, Professor P.J. Devereaux from McMaster, and Paul Karanicholas will formally introduce PJ in a few minutes. But I think the topic of advancing clinical trials and achieving excellence in perioperative research is a subject matter that I think really touches on all of our practices, and I want to thank Paul for suggesting a PJ, and PJ was really fantastic getting to know you a little bit last evening as well. So this is Ben Alman, and Ben's a fantastic guy. He has dual citizenship, so he's American born, but I think he's quite passionate about Canada as well, and he's the former chair of orthopedics here at the University of Toronto. Was very supportive of our combined spine program, so I'm grateful for that support. And then Ben was also my predecessor as the vice chair of research. And I think Ben had this idea to create a lectureship in the Department of Surgery each year that would be kind of dedicated to research topics. And although Ben is now the chair of orthopedic surgery at Duke, and actually is coming up to his 10-year anniversary in that regard, he still has quite close connections with Toronto. So we want to welcome Ben as well. So on that note, I will ask Professor Karanicholas to come up and to introduce our keynote speaker, Professor Devereaux.
Okay, good morning. So it's really a huge honor for me to have the privilege to introduce Dr. Devereaux to you. Dr. Devereaux has been a huge role model to myself and a source of inspiration really since I first met him about 20 years ago. He's always pushed me to really think bigger and broader when it comes to clinical trials. In many ways, Dr. Devereaux is a pioneer in the field of perioperative care. He is the inaugural chief of the Division of Perioperative Care at McMaster University, which is a combination of perioperative internists, anesthesiologists, and surgeons who share both research, education, and clinical care of patients there. He's also the president of the International Perioperative Society. He has led the Perioperative Care Congress since 2017, which is an annual congress focused on that. His research work is very, very well known. As you can see here, he's got over 400 publications, 85 book chapters, over $300 million in research grant funding. In addition to these numbers, or probably more important than the numbers, is the impact of the trials that he has led, really covering topics that are germane to everyday surgical practice that impact all of us in this room and everything we do on a day-to-day basis, with sample sizes ranging from 10,000 to 20,000 patients routinely in his trials. So for those of us trying to do, quote, large trials, it's very humbling to see the trials that Dr. Devereaux works on. But again, it's inspirational, I think, for all of us. Most recently, Dr. Devereaux has started an initiative called the Accelerating Clinical Trials, or ACT Consortium, which is a pan-Canadian network of not just perioperative care, of all specialties, focused on improving the way that we do clinical trials in Canada. So working on many of really the inefficiencies and questioning and challenging, I think, dogma in the way that we do clinical trials. This is supported by nearly $40 million from CIHR to facilitate this. And it's really incredible work that I think will help all of us to do trials better. And I'm sure we'll hear more about that today. So thanks again very much, PJ, for joining us today. And we're really looking forward to hearing you speak.
Good morning. Thank you very much. It's a great honor and pleasure to be here to speak today. I've had the good fortune of working with people in anesthesia and also people in surgery and also people within medicine from the University of Toronto. And one of the things I've enjoyed most about my research focus and clinical aspect of perioperative care is, I think, so I'll just take cardiology as an example. We've super subspecialized within cardiology, and even now getting people to come to general cardiology rounds is hard. And I really I learn a lot more, obviously, from people that have spent years in areas that I've not, and collaborating with them. And it's one of the things I've really enjoyed about perioperative care. I'd like to make one point that achieving excellence, this is aspirational. It's not a passing of judgment of our research program. So please keep that in mind. And it was a pleasure to meet you last night, Ben, and to give this lecture in your name. Okay. So I'm expected as part of our university to put up my disclosures. And based on study questions, I've originated in grants. I've received grants from many different companies, and I've participated in meetings for a number of companies, and I've also done consultancy work for lots of companies. The goal of the presentation is I'm going to first tell you about what has consumed a lot of my time the last year, which just relates to the issue of clinical trials in Canada. And I'll talk first about the Canadian clinical trials landscape. I then want to offer an overview of the Accelerated Clinical Trials Act Consortium, its guiding principles and its structure, our activities to date and upcoming endeavors that hopefully some of you will be interested in. And then I'll talk about my journey in perioperative clinical research. So research demonstrates that Canadians punch way above their weight class in terms of high impact clinical trials. And you don't need to see this research. You just need to open up the New England Journal of Medicine or Lancet any other week, and you will commonly see that a Canadian has led a trial that's in one of those journals. Those are obviously the highest impact journals. Everyone's trying to get their papers in there, and yet we represent less than 0.5% of the world population. We hit way above our weight class. We should take great pride in that, but we should also not only take pride in what we do well, we should actually recognize and acknowledge where we struggle. And I think that there is no ambiguity that COVID-19 pandemic uncovered that we have some serious structural issues in Canada when it comes to conducting clinical trials. I put forward to you that the successful Canadian trials have primarily occurred due to researchers having the mindset of a long-distance runner. Trialists have succeeded because of perseverance, not because of the system. COVID-19 required trialists to sprint, and the problem is the system didn't really let people sprint. The reality is we didn't have trials from Canada that influence care around the world, despite we have trials all the time in Canada that are influencing trials or care around the world, but during COVID, that never happened. And we should ask ourselves tough questions of why that didn't happen. We then became dependent on countries like the UK, who were able to pull off trials incredibly efficiently that actually change care, save lives, and really revolutionize the way that we manage people with COVID. And we should ask ourselves, why was that possible? And why didn't that happen in Canada? Basically, the Canadian government, I think, was embarrassed by how things went with COVID. They made a massive investment into basic life sciences strategy, and most of that money is going into biomanufacturing, biotechnology, but they also realized for biotechnology, you need clinical trials. So they've invested $250 million into clinical trials. Most of that money went into open competition. They also funded 7 training platforms, and they funded 1 Pan-Canadian Clinical Trials Consortium, which we were fortunate as a group to get funding for, and that was the Accelerated Clinical Trials Act Consortium. And our funding was really, we based our proposal was to address what we saw as the challenge that really did impede us during COVID, but also impedes us in everyday life. Even though we succeed, we should be succeeding much faster, much easier. So the guiding principle of ACT is that our activities will accelerate, optimize, and facilitate the conduct, implementation, and results translation from high quality, high impact RCTs to improve health in Canada and around the world. This is the structure of the ACT consortium. At the base is Canada's biomanufacturing and life sciences strategy. And then we have on top of that of our platform, we have 11 clinical trial units geographically located across Canada. And they have the infrastructure and personnel to conduct clinical trials. Then on top of our platform, we have pillars, and those pillars are research networks of researchers in different disease states, patient populations, interventions. And then we have 28 of them within ACT, and they span from pregnancy through to palliative care. That being said, we do not cover all things for sure. Coming across our pillars, we have cross-cutting enablers, which are working groups trying to address a number of the barriers that exist to facilitating the efficient conduct of clinical trials in Canada. We have a knowledge mobilization committee at the top of this, and then overarching all this is our governance structure. The grant was announced January 19th, 2023 by CHR that we were funded. Since then, we've established 22 committees and working groups, co-chairs, memberships, and terms of reference for all these groups have been established, and these groups have met over 200 times at this time. This shows a pictorial of our structure in terms of working groups and committees. The blue are the committees, the operations committee is the central committee, and then the yellow is our working groups, and then we have an international and a national advisory committee. We held our first request for applications RFA. We announced it on February 27th of 2023. It was to support high impact clinical trials that needed some help to get to the goal line. Submission deadline was April 3rd. We had 43 applicants from 19 ACT networks. Obviously, there's lots of challenges with peer review. We've not overcome all the problems, but one of the things we have made a very strategic effort to do is that we have very targeted peer review. So as an example, for this first one, it could only be people that led large international trials that could actually evaluate the trials. And each trial submission was scored by 5 independent reviewers. We had 11 successful applicants. We announced this on May 18th. We had funding for just under $2 million. And importantly, several of these trials now have actually completed, been published in New England Lancet, been presented as late-breaking clinical trials, and some have actually changed clinical care. So they've been very high impact trials. This just shows you a quick pictorial of the 11 trials that were funded. Artesia was most recently just published, which demonstrated in patients with pacemakers, where we see short episodes of atrial fibrillation less than 24 hours, that anticoagulating those patients actually results in stroke reduction in the coming several years. And this is really having a big impact in terms of clinical care. We held our first annual ACT Consortium meeting on April 17th, 18th in Hamilton. The focus was to discuss the ACT goals, structure, and bring Canadian biotech company together with our research community. So we brought together 65 Canadian biotech companies. I'll talk a bit more about our focus on this in a moment. And we had 300 researchers from diverse areas across the country. We wanted to connect people with biotech because we're going to have a funding opportunity that would focus specifically on funding trials to evaluate Canadian biotechnology. Also, we had a number of policy issues discussed. One important point that we made a decision on at the first meeting was to try to move to create a single national distributive REB model, such that if someone in accredited REB in Cape Breton Island approves a trial, it should account for all of us across the country. So it should work in BC and vice versa. We're spending way too much time having endless reviews. It's a lot of time, money, and energy, and it doesn't actually help us. And that was one of the decisions that we made to aspire to. We had our second RFA announced April 11th. We had 2 streams of funding. Stream 1 was non-traditional trial design, so not your typical parallel group designs. Could be cluster crossover, it could be stepwise design, just something that was a different type of design. And Stream 2 was looking to do trials within trials. How do we improve the efficiency with doing clinical trials and actually evaluate in a systematic way that we can be confident about the results? We had a submission deadline of June 8th. We had 33 applicants for Stream 1, 8 applicants for Stream 2. Each applicant, again, was scored by 5 independent reviewers. We had 8 Stream 1, 5 Stream 2 successful applicants with just under $2 million in funding. And this just shows you the Stream 1 applicants that were successful. And we had people from diverse areas. We had people from anesthesia, the periop, and surgery groups did well. Paul also was one of the people that was funded within this funding structure. We also have a target of trying to improve the democratization of clinical trials in Canada. We want to create equitable access to clinical trial participation. It is for certain, if you live in downtown Toronto, you have a reasonable chance that you'll have access to trials that are happening, but that is not true across most of our country. And ideally, we would like to have it so that Canadians have access to trials that are relevant to their health. I'm going to tell you a bit more about our portfolio system in 1 second. We're also creating novel partnerships with pharmacies. So we're working specifically with Shoppers Drug Mart to start, where ideally we're getting relationships in terms of getting access to drugs cheaper, participation in trials, but also even potential identification of patients in more remote areas where we don't have great research set up. We've also set up a communication strategy to try to make people realize that they are an important part of advancing clinical trials and they can be part of the cure. So it's called the Be the Cure strategy, which we were very fortunate to build off of work that was done initially within Alberta on this. We set up a national portfolio competition. So one of our International Advisory Committee leaders, our co-chair is Martin Landry, who was one of the co-PIs of the recovery trial. And at our first presentation, Martin spoke about the recovery trial. And one thing that was very clear about the recovery trial, several things were important to how it worked, but 2 things were very fundamental. One was they had a national single REB approval process in the UK for 12 years now. So Martin and a colleague wrote the grant within 6 days. 2 days later, they had national ethics approval. But importantly, 15 years preceding this, the UK government had set up a portfolio system where they embedded study personnel in every hospital in the country. And many hospitals had many study personnel. If they did well, they got more study personnel. Now, there's many stories of why did the government set this up. Probably the most credible one is that there was Big Pharma threatening to leave the UK because they said this country's not efficient 15 years ago. Government made a decision to invest in this and embed study personnel, which made them way more efficient. What was so crucial to the recovery trial was the day after this was approved, every hospital in the country was recruiting into the recovery trial. There wasn't calling colleague and saying, hey, can you find study personnel? And 4 months later, you're through HR and you might have someone hired. The next day, people were recruiting, and that's what allowed it to happen so fast. This also within the UK gives great more democratization of clinical trials. People have access to it because it's happening all over the country. So we want to encourage our government to create a portfolio system in Canada. We made a decision that we'd have an open competition where we invited community hospitals across the country to apply for funding, and if successful, we would give money to embed study personnel in their hospitals for the next 3 years. We announced this in February, had a submission deadline of April 14th, had 41 hospitals apply from across the country, had their applications ranked, then we did interviews with all of the applicants, and a committee that reviewed them scored them, and we funded 20 portfolio hospitals from 9 provinces and 1 territory. This just shows you pictorially where these came from across the country. And this just shows you the centers that came across. And there's some great centers that I'm very optimistic will do a great job. We also want to try to focus on how do we grow the funding pie. So I'll just say personally, I have wasted too much time debating how do we divide CHR money between basic scientists and clinical scientists. And I will acknowledge that is not helpful. We need to figure out how to grow more money. And I mean, okay, we should keep pushing government. Hopefully they'll put more money in, but that's not, I think, should be our biggest strategy because it's a difficult strategy. I've been very struck. I've been involved with a lot of big grants from Europe where they give crazy money compared to what we'll get in Canada to do a clinical trial with one condition. You must bring in European small and medium-sized biotech companies. Europe not only wants to improve health, they want to grow their economy. And even though I'm focused on perioperative vascular events, which I think matter, I will acknowledge that our economy is a profound determinant of health, and any of us just need to find ourselves unemployed to very quickly realize how profound a determinant of our health it will be. And we should be looking to grow our economy and address health issues at the same time. And that's why we're making a big focus on trying to bring Canadian biotech together with researchers and specifically fund actual competitions that will actually focus on our Canadian biotech. And again, it's, Canada has no big biotech that we own. That doesn't mean it has to be like this. It's not that Europe and America are the only ones destined to have that. It's simply they invest a lot more money. They put a lot more effort. As a community of trialists, we need to do our role. And part of it is, I think, most of us as Canadians don't even know what Canadian biotech exists. We don't tend to think about doing research on it. We need to bring those communities together, and we as a country and as a community need to invest a lot more to say, well, we're going to study Canadian biotech with the hope some of it will succeed and some of it will stay Canadian and some of it will grow. And then we can get to a place where hopefully we can have big biotech. If we have big biotech, that will create a lot more opportunity for trials within Canada and a lot more funding opportunities for researchers within Canada. We're also working with big European American pharma and device companies. They want to bring more trials to Canada. What impedes them frequently is the inefficiency of our system. So they're a great partner aligning with us to address some of the system issues that hopefully will allow us to bring more trials here. So we held our third RFA, announced on May 12th, focus on Canadian biotechnology. Submission deadline was July 17th. We had 30 applicants from 17 ACT networks. Targeted peer review. This time we had 5 people in biotech evaluate each grant, 5 clinical trialists evaluate each grant. We had 5 successful applicants with $2 million in funding. And again, Paul has been successful. Surgery's done very well within these granting opportunities for Canadian biotech. We held our second annual ACT Consortium meeting on April 21st, 22nd in Charlottetown. The focus was bringing our portfolio hospitals together with all of the networks and researchers and getting them embedded, getting them going with trials. We also, as some of you may be aware, good clinical practice, which maybe not quite good, maybe not clinical, maybe not practical, nonetheless exists. It's a religion. It's under review right now in terms of a change that's happening with Revision 3. So we had lots of discussion about that. And then afterwards, we made a submission to Health Canada with our proposals to these changes that are being proposed. We also had further discussion about our single national distributive REB model with clear timelines related to this. And we recognized and celebrated the first and second RFA winners. We also are trying to work on improving Indigenous people's access to clinical trials. Complicated issue. Basically, there's a big push in CHR to try to include Indigenous people in all trials. I think we should include any Canadian who wants to be part of the trial and make it accessible. But in the end, people have to decide whether or not they want to be part of trials. And from our work within that community, what became much more obvious is that it was better to first work within the communities to decide within the 3 Indigenous communities what were their health priorities. And then, so that we're just finishing that work now. And then we'll be funding trials specifically to only be undertaken within each of the 3 Indigenous communities that are targeted to their health priorities for credible interventions that are relevant to them, that will be conducted by Indigenous leaders to see what we can advance within those communities. Reflection, a lot has happened within the first year. Lots of gratitude for the co-chairs, committee members who worked diligently towards the ACT goals, the ACT networks and CTU leaders, the RFA reviewers and portfolio review panel, our partners, and our Central ACT support team. Currently, we have RFA 4 out for funding, which is to create new networks. And hopefully we'll have lots of people from anesthesia and surgery applying for funding to create new networks within their areas and domains. We have planning subsequent RFAs that will be coming up soon. Have a big meeting coming up in late February, focused on, again, this single national distributive REB model and strict timelines and how to achieve that. And we're also doing ongoing work right now with master clinical trial agreements, trying to address the really huge challenge that exists with getting agreements done between centers and the time that we're spending on that. Our timeline is short. So CHR announced it January 19th last year, backdated to September 1st, 2022, and it was a 3-year grant. So we have less than 2 years left. So we need to focus on delivering what we said we would do, collaborate with key stakeholders, think strategically regarding arguments to bring required groups together on side and have a big picture perspective. And we have to move past regional politics, which at times become real issues. If ACT can overall be successful and we get a permanent efficient system implemented with government implementing sustained funding for RSTs, Canadian biotech grows, and more big pharma and device companies bring more trials into Canada. Again, we then think we can improve, and this will be to the Canadian benefit for our public. I'm now going to switch to talking about my experience in perioperative RSTs, focusing on controlling the sympathetic system, coagulation system, and platelet system, hemodynamics, inflammatory system issues around the timing of surgery, and virtual care with remote monitoring. The first trial that our group undertook was the POISE-1 trial. In this trial, we randomized 8,351 patients in 190 centers in 23 countries to receive a beta blocker or placebo around the time of surgery. Preceding this, there have been 2 small trials, just over 300 patients, suggesting that beta blockers around the time of surgery had a 100% reduction in myocardial infarction and an 80% reduction in death. Based upon this, guidelines were written saying you should give beta blockers. And in the United States, there was system issues where if you didn't give beta blockers, hospitals were penalized for not giving them. In POISE, a lot of important lessons we learned. Our primary endpoint was a composite, and it highlighted the problem that exists with composites. Our composite was cardiovascular death, non-fatal MI, and cardiac arrest. And this was reduced with beta blockers, 244 in the beta blocker group, 290 in the placebo group, hazard ratio of 0.84, result that is statistically significant. However, this result was completely driven by a reduction in myocardial infarction. If you give beta blockers acutely to patients undergoing surgery in high enough doses to control the heart rate, you will unequivocally lower the risk of myocardial infarction. There's a clear benefit to beta blockers. There's no ambiguity. The evidence is overwhelming for that point. What was unknown was that mortality went up with beta blockers. 129 deaths in the metoprolol group, 97 in the placebo group, and stroke went up, and they were devastating strokes. 30 people died with a stroke. Those who survived, 2/3 incapacitated, needing help with everyday activity. And we doubled the risk of stroke with the beta blockers. Importantly, how did this happen? So again, you can never be 100% sure, but a lot of analyses that we did seem to suggest clinically significant hypotension back on surgical wards is a very common pathway to which a lot of these things can go wrong. Number one, clinically significant hypotension is not uncommon. It happens for many reasons. It can be, patient can have bleeding, patient can have sepsis, patient can have heart failure. There could be a whole host of reasons. If it happens on the surgical floor, just the reality, and it's not going to change, our nursing to patient ratio is such that it can be delayed being recognized for hours. And that can get patients into serious trouble. And when we have a beta blocker on board, we dramatically increase the probability of that significant hypotension, and you make it much more difficult to treat and make it much more difficult to reverse what's actually happening, and that's how people get in trouble. So again, there's a clear benefit to beta blockers, but you can get yourself into serious trouble. So insights from POISE 1 was that there is this clear benefit, there is this potential harm. It highlights the importance of clinically significant hypotension and hemodynamics in the perioperative setting. Most importantly, when we get out of the OR setting, it matters in the OR, just that there's someone there who's paying close attention and will treat it. The problem is when you leave that setting, our reality of nursing to patient ratios is such that hours go by before it's detected. It also identifies why, in fact, we need large trials, but also the potential for controlling the sympathetic system and the potential that that could actually be the pathway for which we can get benefit, but we have to figure out how to do it safely. We next moved on to clonidine because we did work where with clonidine alpha agonist, we could see less hypotension compared to what we're getting in beta blockers, and we thought this may be the pathway to controlling the sympathetic system. It wasn't. In POISE 2, randomized 10,000 patients, clonidine versus placebo, and we didn't see an impact on myocardial infarction, and we didn't see an impact on mortality in contrast to beta blockers. Now, the discordant results likely are explained when you look at the physiology of what happened between the two trials with these two drugs. Clonidine resulted in way less heart rate control, and heart rate control in all of our research ends up being shown up to be very important in terms of the probability of whether or not you're going to end up with myocardial infarction. So it's likely why we didn't prevent myocardial infarction. We just didn't get the heart rate control we needed. Clonidine did result in a lot less hypotension compared to the beta blockers, and that's likely why we didn't see the impact in terms of mortality or stroke that we saw with the beta blockers. And this raises the issue that the ideal perioperative sympathetic control may require getting an agent which will control heart rate, but mitigate or minimize the hypotension. Right now, we're doing a big trial on ivabradine. Wojtek Szczeslik is leading us in this trial. It's it affects eye funny channels. It only affects heart rate, has no effect on blood pressure. And there's other strategies. We still think that beta blockers make them back, but it'll be with virtual monitoring technology that will allow for the early identification of hypotension. We also in POISE 2 tested aspirin, and here we had basically two trials in one. Roughly half the patients were on chronic aspirin, had to stop at least 3 days before. The vast majority stopped at least 5 days before. Then the day of surgery randomized to start aspirin or placebo, and roughly half the patients were naive to aspirin, started placebo on the day of surgery. What we saw was that there was no impact in terms of cardiovascular death or myocardial infarction in terms of aspirin. However, there was an unequivocal increase in the probability of major and the composite of major life-threatening bleeding when aspirin was given perioperatively. It is likely, because we know from a lot of imaging studies that we've done acutely with people having MIs, there are some people that are having thrombotic MIs, and we know thrombosis is a perioperative reality. But supply-demand mismatch is likely the dominant pathway through which MI happens. So the problem is you're likely preventing some thrombotic events, but at the cost of bleeding, causing a counterbalancing supply-demand mismatch MI, and you see no overall impact on MI. But you do see this increased risk. The exception to this was in our subgroup of people that had prior PCI and had stents. So in patients that have had prior PCI, there was a clear, unequivocal reduction in the risk of death and in myocardial infarction in those who continue their aspirin around the perioperative period. The reason being, those people have a much higher risk of thrombotic myocardial infarction. That's likely why these patients benefit in contrast just to general people having non-cardiac surgery. I want to make a point that within trials, it was observations within our trials that then led to a lot of big epidemiological studies, which really then led us to even more trials from discoveries from these epidemiological studies. So I'll just briefly mention two. The first was VISION. VISION was a 40,000 patient prospective cohort study that we did that was driven from a patient that I saw on POISE 1. And from there, we developed the concept of myocardial injury after non-cardiac surgery, MINS, which is when patients have troponin elevations after surgery due to ischemic etiologies. Those patients are on a very profoundly different trajectory for the coming weeks, months, and year compared to patients that don't have that. And then we also, a big challenge that exists in perioperative medicine, and I say this as a cardiologist, we tend to downplay bleeding, and every myocardial ischemic event matters. It is not true that every myocardial ischemic event matters. They do matter in general, and we are way underappreciating the importance of bleeding. Bleeding initiates a whole cascade of pathways that get a lot of our patients into trouble. We wanted to establish a definition of bleeding that would have similar prognostic relevance to myocardial injury that would both impact death within the first 30 days. So we developed the concept of bleeding independently associated with mortality after non-cardiac surgery, BIMS. We also, within Vision, had a sub-study looking at covert strokes in patients having non-cardiac surgery, demonstrating that across non-cardiac surgeries, people age 65 or greater having in-hospital surgery, 7% of people, if you do a brain MRI using diffusion weighted imaging, will have a new covert stroke. And that those covert strokes have real implications both for short-term delirium, but also cognitive decline at 1 year and the risk of overt stroke or TIA in the coming year. We then did a similar study within cardiac surgery, the Vision cardiac surgery study, which was 16,000 patients. And there we've now developed the concept of myocardial injury after cardiac surgery. And we have done work to show what troponin thresholds matter. They are profoundly different than what the guidelines say. And we have an important paper coming out showing and really upending a lot of the issues around ECGs in people that are having myocardial injury after cardiac surgery. The MINS work then led us to study how can we actually improve the outcome for patients that get myocardial injury after surgery. And this is the MANAGE trial, which we published in the Lancet, where we randomized patients to dabigatran 110 milligrams BID or placebo who had suffered MINS. And we demonstrated that if you give patients dabigatran, you can substantially reduce the risk of recurrent major vascular events. And I want to draw your attention to a few points on the Kaplan-Meier curves. So what you see is that in the first 2 weeks after people suffer MINS, 5% of people within the control group will have a recurrent major vascular event. The curves immediately diverge when you give dabigatran. They continue to diverge for about a year and become parallel and stay parallel out to about 2 years. But even at 2 years, it's not obvious that we've seen a plateau of the events, but the event rates are profoundly higher than people who just present to our emergency room having a myocardial infarction. They have a way worse outcome. Now, partly the reason they have a worse outcome is they're not managed very well. And part of it is we just don't have enough research to figure out what is the optimal management, but they're having much worse outcomes in terms of events. The problem is people aren't following them. People aren't identifying the events. And, no one connects that someone who had surgery, 6 months ago, who now drops dead tomorrow, that they had myocardial injury, no one knew about it. They have a recurrent massive event and die, and no one knows what actually happened. Timing of surgery is another area that we get into. This is Dr. Flavia Borges, who's worked with Dr. Mo Bandari and I in the HIPPOTAC 1 trial, and Flavia is now leading us in HIPPOTAC 2. HIPPOTAC 1, we published a couple of years ago in the Lancet, and the impetus for this trial was that 10 years ago, I was consulted to see this 73-year-old female who presented with a hip fracture, and the referring person who called me said, look, you're going to have to fix this heart issue. She's troponins are up. She's in some heart failure. And before we're going to be able to fix this hip. And at the time, I knew nothing about the observational data on the timing of hip fracture surgery. Like most things, we infer a lot of information from one situation to another with patients. And the course of action in terms of our management that ended up happening with this patient ends up getting some antiplatelets. The patient ends up bleeding. They die. They never make it to the OR for their hip. And this certainly, cognitive dissonance being what it is, I'd like to say she had bad protoplasm. But despite the best of intentions, the path we selected actually did not help this patient. And this then raised a question in my mind, maybe this approach of medical optimization of acute surgical patients, maybe that's not the right approach, at least for some conditions. And this is what led to the HIPPOTAC trial. We raised the question of, should we be looking to accelerate the time of surgery compared to the normal timing, and would that have the potential to improve outcomes? So we randomized just under 3,000 patients who had had a hip fracture due to a low energy mechanism. We had 69 centers, 17 countries. Accelerated surgery, the goal was you'd be in an OR within 6 hours of the diagnosis, and standard care was whenever it happened, it happened. We weren't delaying surgery. It ends up being that accelerated surgery, we were able to achieve our goal of 6 hours, and standard care ended up being 24 hours after the diagnosis. People on average had surgery. Among patients with hip fractures, accelerated surgery did not significantly lower the risk of mortality, major or a composite of major complications. It, however, showed no evidence of any harm, even in patients who had medical conditions at the time of the presentation of their hip fracture. And I'll tell you more about that in 1 second. What it did show is that accelerated surgery unequivocally lowered the risk of delirium. It lowered the risk of UTIs, and basically because everyone ends up getting Foley catheters put in right away. And the longer you wait to have surgery, the longer that catheter ends up being in, and the more likely you're predisposed to get UTIs. We also had substantial reductions in moderate severe pain. We also showed much faster mobilization, standing, full weight bearing, and shorter lengths of stay. And we have the 1-year data coming out showing dramatic reduction in overall costs, even out to 1 year, because you get people out of hospital so much faster. Importantly, the patient who was the driving factor for the HIPAATAC-1 trial, the patient who presented with elevated troponins, myocardial injury, that subgroup, we saw a big mortality advantage with accelerated surgery. And this is what the focus of HIPAATAC-2 is. So we're randomizing people right now who show up with elevated troponins, hip fracture to accelerated surgery versus normal timing. But also just the point to make to you, if people show up with a hip fracture and they have an elevated troponin, the probability of death in the standard care group at 3 months was 24%. It dramatically differentiates who's going to do well and who will not do well. If you're showing up and you're showing that you have stress in the myocardium with your fracture, it tells you the heart does not like the physiological stress of that fracture. Now, whether it will be the right approach to accelerate the surgery, we will see with HIPAATAC, but it also raises for a lot of other acute surgical conditions where people look unstable. Yes, it's possible medical optimization is the right path. It's also possible very fast surgery is a better path. We also have gotten into the issue of virtual care with remote automated monitoring. Dr. Michael McGillian has been leading a lot of this work with me. We published our first trial, PVCRM1, during COVID in the BMJ. We took patients age 40 or greater who were being discharged after non-elective surgery. We had just over 900 patients, and they're randomized to go home with virtual care with remote monitoring technology or standard care, normal follow-up, whatever happens. We had 8 centers in Ontario and Alberta participate. This is the technology. It's very simple. So it's a tablet. Patients can press it, instant interaction with nurse, and via the nurse, the physician. And also all of it is Bluetooth enabled. So they put the cuff around their arm, press the button, measures blood pressure, uploads onto the tablet. The tablet's cellular enabled. We have the results within seconds. And then we have parameters set that it should alert people. Key thing about technology, we all believe in technology. I believe in technology. We can be believing that technology, if it's good, it'll find a cure. That is very conditional, we learned. If we set very specific thresholds saying if blood pressure below this, it must be accelerated to a physician. Blood pressure above this must be accelerated. If the heart rate's below this, above this, temperature's this, weight changes this. But centers could rewrite those thresholds. And as it turns out, some centers rewrote the thresholds, which then had a dramatic impact on the outcome. So you can have great technology that tells you the problem, but if no one is addressing the problem and care does not change, you will not change outcomes. I know that's an obvious statement, but I just want to drive it home with some of the data. So we ended up having very different centers. We had high escalation centers where 89% of the patients had escalation of care from the nurse to the physician because people were outside of our physiological boundaries. We had some centers where only 55% of the time this happened, and we had some centers where only 34% of the time happened. And it's not explained by the surgeries that are happening at these sites. It's explained by a variation in terms of the thresholds being set. And it's even, if you look at the number of escalations, it's even that there's way more escalations happening even per patient. And then if you look at what happens in terms of change in medication, again, dramatic differences in the number of change in medications happening in high escalation centers compared to intermediate and low, which again, as you'd expect, if you don't change care, you won't change outcomes. And then what do we see? The high escalation centers, when we look at acute hospital care, that is ER visits or hospital admissions in the next 30 days, dramatically reduced in the high escalation centers. No impact on intermediate low escalation centers. Same thing for brief acute hospital care. Big impact in the high escalation centers, no impact in the low intermediate. ER visits, big reduction in the high escalation centers, no impact intermediate low. Hospital readmission follows the same path. So what we saw in PVCRM1 was high rates of acute hospital care post-discharge, even during COVID-19, 27% in the standard care group. In the centers with high escalation of care and management, we saw 40 to 50% relative risk reductions in acute hospital care, brief acute hospital care, ER visits. It is only credible to expect virtual care with RAM to impact outcomes if we identify change and we actually change care. And again, I think sometimes technology doesn't fail because it's bad technology. It fails because we don't have systems of who's going to address the problem in a timely manner with the hope that magically someone will deal with it for us. We have to set up the structures that lead to the change that will actually allow better outcomes. Coming back To our issue of bleeding, we then undertook POISE 3, focused on the issue of bleeding, and looked at tranexamic acid. So we randomized just over 9,535 patients, 114 centers, 22 countries, 99.9% completed a 30-day follow-up. And what we demonstrated was the composite of bleeding outcomes, which is life-threatening, major bleeding, critical organ bleeding, substantially reduced unequivocally with TXA, 433 events, TXA group, 561 in the placebo group. Composite of vascular outcomes, so 649 vascular outcomes in the TXA group, 639 in the placebo group. So just under 1,300 events with an absolute difference of 10 events between the two groups. Hazard ratio 1.03, p-value 0.04. We set a non-inferiority boundary, which I'd be happy to explain why we did it, of 0.0125, which was not met. But certainly the data suggests that the probability of a meaningful difference in terms of vascular thrombotic events is exceedingly low. Moreover, if you put our data into a meta-analysis of all the data that exists beyond POISE 3, again, there is not data suggesting that there is an increase in thrombotic events. We then look at BIMS, our primary secondary endpoint, major bleeding, ISTH bleeding, transfusion of 1 unit or more, transfusion of 2 units or more, transfusion of 2 to 4 units. Every one of these things reduced with tranexamic acid substantially, typically by 25 to 30%. So insights from POISE 2, TXA among patients undergoing non-cardiac surgery. TXA reduced the risk of composite life-threatening major critical organ bleeding. Although TXA had no significant effect on major vascular complications, non-inferiority was not established with the threshold that we set. Our results also demonstrated a 95.6% probability that the primary safety endpoint with a hazard ratio less than 1.25 was in fact the case. This is Dr. Maura Mercucci, who recruited from Italy, who then led within POISE 2 our partial factorial looking at issues around hypotension in the perioperative setting. We published these results just last year in the Annals of Internal Medicine. We randomized just under 7,500 patients to a hypotension avoidance strategy versus a hypertension avoidance strategy. The hypotension avoidance strategy was that during surgery, we'd ask people to target the anesthetist map of 80 or greater, and before and for 2 days after surgery, hold ACE and ARBs and continue other antihypertensives based upon an algorithm based upon what the blood pressure was. Hypertensive avoidance strategy was during surgery, target a map of 60 or greater, and before surgery and the first 2 days after surgery, give antihypertensives, whatever they're on, they're on. They had to be on an antihypertensive to get in the trial. So a long-standing question is, what do you do with antihypertensives? There's been a lot of reservation about ACE and ARBs and a lot of uncertainty about how do you manage these optimally. And obviously we knew from POISE 1, there's the potential that antihypertensives, you can get into trouble, but this is a different scenario. This is people on chronic antihypertensives who've already declared that they tolerate these drugs. What we demonstrated was that 14% in both groups had a major vascular complication. So these two strategies did not result in a difference in terms of major vascular outpoints. What it also demonstrated, though, importantly, was that there was very small mean differences in blood pressure and heart rate between the two groups, which likely explains why we're not seeing any important differences in terms of major endpoints. Importantly, we saw no dose effect based on compliance. So there's some compliance issues that can happen, certainly with ACE inhibitors, but even in the centers that have really high compliance with the issue of ACE inhibitors, we still don't see effect happening. Significance is that it informs important questions commonly confronting physicians. Should we target MAPs of 80 or greater than 60? It's likely for most patients, 60 or greater is okay. It doesn't mean there can't be select patients where in fact it'll be different, but it's not that we're seeing dramatic difference. There is some MAP below which you're going to get into trouble. There's no doubt about it. But in general, what we see so far, 60 or greater looks okay. And when it comes to the issue of our antihypertensive, the perioperative setting, in general, if most people are on it and stable, they likely will tolerate it. However, if people are coming to surgery and they're towards hypotensive to start, it's only rational to hold it. But in general, can you continue in most patients? Yes, you can continue in most patients, and most patients will do okay because they've already declared they tolerate this drug and they're okay with it. Finally, this is Dr. David Cohn that I recruited from Switzerland, and we did some initial work with colchicine, and then David and I did a trial which we just published looking at the effect of colchicine in patients having thoracic surgery, and this is trying to affect the inflammatory pathway. So in the COP-AF trial, we randomized just over 3,200 patients in 45 centers in 11 countries to get either colchicine or placebo around the time of thoracic surgery. Our co-primary endpoints, the first one was clinically important atrial fibrillation. This occurred in 103 patients in the colchicine group, 120 in the placebo group, was not statistically significant, but in the direction of benefit. And MINS, myocardial infarction non-cardiac surgery, showed a similar signal, direction of benefit not significant. But the composite of these endpoints was statistically significant and reduced with colchicine, and also a broader composite that included some other major vascular events that we were interested in was also statistically significant, consistent with the data that we now have in big cardiovascular trials in the non-surgical setting, showing benefits of colchicine, reducing through inflammatory reductions, major vascular complications. There is an increase in diarrhea, but importantly, the diarrhea is benign diarrhea. If you stop it, it resolves, and we didn't have any major issues that happened with the diarrhea. Insights from COP-AF is that although we didn't reduce the primary endpoint of the individuals of AFib or MINS, its composite was reduced, and this is encouraging results. We don't see any major safety concerns, and we do think the inflammatory pathway is going to be an important pathway. We're trying to get funding for POISE-4 right now, which we hope will be a big trial in all of non-cardiac surgery with enough events, and we can show reductions in overall vascular events. So in conclusion, I want to always come back to a point. Even though I'm focused on complications, we should never lose sight of the fact people have surgery for important reasons. We should get to a place where we can either prevent complications or manage them well enough that people do not get denied surgery because of risks. We're not there, but that should be our goal. And we should not lose sight of the fact that people pursue surgery for important reasons. The sympathetic system, the coagulation system, inflammatory systems, hemodynamics, system issues around timing of surgery and virtual care are some pathways that I think have real potential. We can improve outcomes for our patients, and lots more research needed, but I think we're on our way. Thanks so much.
PJ, thank you for that amazing talk, and it's really, I think, quite remarkable that this infrastructure that's been created to run these trials to address some important questions. I wanted to thank a few people before we then go into a Q&A. So I wanted to specifically thank Renata Musa and Sylvia Perry for their amazing help this morning putting this together, and also to Carol Swallow in the Department of Surgery for support. So Sylvia, Renata, I have a technical question. I know that we have people online. Should I click on the chat or the Q&A? Will you be highlighting questions for me? Okay, good. So, okay, so let me just have a look here. Okay. All right. Okay, so Sylvia, if you can then feed me some questions. So I think just while we're waiting for that, perhaps I'll just ask anyone in the live audience here if they might have a question. Dr. Alman.
Yes, I mean, that's a fantastic talk. I think it really done very nicely. Well-powered with trials that help inform us. But I had a question for you in the Canadian network about democratizing research. So I think that's a really important thing, that the patients in our trials match the patients in our population. And if the patients for people coming to the hospital, it's easier because you know who comes to the hospital. How are you thinking about, or are you thinking about, patients who aren't coming to the hospital, people who might have like single joint pain or back pain and stuff like that? How are you thinking about, or how are you thinking about democratizing that across the country?
Yeah, so definitely really important. We're definitely thinking about the issue. The two ideas that we have around it, the first is pharmacies, because there's lots of people who don't get admitted to hospital, but lots of our patients with chronic conditions go to pharmacies, and go to pharmacies all over our country. And pharmacies can be a really crucial pathway for helping us to identify patients to get involved with trials. This has become a big issue in the States. Obviously, you're very aware, Ben, that Walgreens and others have invested a lot of money in terms of getting into the clinical trial space. And, I think we have to think through novel partnerships, how to work with them to help recruit patients, even retain patients. And I think that's one potential pathway. Through the portfolio hospital, even though it focuses at the hospital level, it's not only meant to be patients that are in the hospital, it's meant to be within those communities. So importantly, there's an expectation of outreach into actually the community setting within those. I think, you know, my goal is that we do try to get the government convinced to do what the UK did. If we can create a portfolio system, I think that'll be the biggest thing to really help create much greater democratization of access to clinical trials for Canadians. I think that is the key. And also it'll make sure that if we confront another pandemic, we won't be dependent on the rest of the world to solve the problem of the pandemic for us. We'll be able to address the problem ourselves. But if we do not have it, we will just never be able to do trials fast enough. It takes too long with the current structure we have because we don't have personnel in our own hospitals that we can control.
Great, and I would just encourage, again, people online to post questions in the Q&A, and we'll be monitoring that. So I think if Dr. Dare has a question, then Dr. Orser.
Two quick questions. The first is, you talked a lot about administrative efficiency within trials, which is obviously a big problem in Canadian setting, because there's statistical efficiency as well, and one of the ways we often approach trials, obviously, as clinicians in particular, through a frequentist paradigm, but particularly your thoughts on the role of phasing approaches within the trial network, and so potential method of statistical efficiency. And then the second is your maps were really impressive within the international reach. One of the challenges is 70% of our world population are lower than the countries, particularly sub-Saharan Africa and Southeast Asia. Getting trials that are relevant and trial outcomes and data that are relevant to those populations is very, very challenging. There has been sort of two approaches. One is to try and widen international media with type work is doing. The other is to try and take the same approach to different communities that are really led by local priorities. What considerations have you had for expanding your trial groups into the low-income countries, recognizing some of the excellent work done by people like have made up that really showing perioperative outcomes can be quite different on those resource contexts in the same country.
Okay, great, thank you. First, just I'll repeat it online. First comment was about how to create more efficiency statistically within trials. You may not like my answer. I don't even like my answer, but I'm convinced of the truth of my answer. People are endlessly looking for a way of how can I make a trial smaller to get a clear result. It's not, I don't think the important point is the issue of the Bayesian versus frequentist, but everyone reaches for Bayesian because they want to drop the sample size. That is the truth of why they reach for it. And that's always the outcome. And why? Because people make an a priori assumption. And the problem is the a priori assumption. And even if they say, I'm going to ignore that, they always result in a smaller sample size. I will argue to you that I've done one trial. I've been involved. I showed you a number of trials, been involved with a lot more trials. I've only involved with one trial in my life that I'm actually confident is adequately powered. It's POISE-3 on TXA. So we have 1,000 events of bleeding. There is no ambiguity about the result. The truth is, it's an uncomfortable truth, but there are so many overwhelming examples where small trials just do not give you reliable answers. Both they're beneficial and they're not beneficial, but they suggest there's no effect and there is an effect. If we want to know answers, it's an uncomfortable truth. You need big trials. You need lots of events. That's what you really need. The issue is events, and there's a lot of research on this, but in general, until you start getting over 500 events, the likelihood that subsequent trials will come along and offer an alternative explanation that are bigger is high. So you got to get high event rates. So unfortunately, there's no statistical simple answer, but cluster crossover as an example is a very appealing approach where you can do it much more efficiently. So like I think there are a lot of efficiencies that can happen. You take some statistical hits, but from a cost and efficiency point of view, you can do things way more efficient. So there is that, but you just need a lot of events. In terms of the issue about, obviously, you know, first and foremost, we're focused on Canada, but it is a rich country. We also should be thinking internationally, and as healthcare providers, we want to change care not only in Toronto, Hamilton, but improve health around the world. So we should be thinking about low middle income countries. Certainly in our Perioperative program, we've had a lot of involvement of low middle income countries. There's lots of benefits to that. Within ACT, our first focus has been trying to sort out the Canadian context. There is upcoming debates and discussions happening that will relate to subsequent RFAs that will look at the international level. I do think as a collective, we have to, it's a really important issue. We owe it to other people. There's lots of suffering happening elsewhere, and importantly, similar to the Indigenous issue, I do think taking trials within communities focus on their health priorities is really important. And sometimes we have the same health priorities, or we have at least enough interest within priority X that people are happy to collaborate. But we shouldn't negate that there are some real issues that are unique to groups of people, and we shouldn't be just simply only focused on the issues that matter to us. At the same time, we have to focus on what do matter to Canadians. So it's finding that balance.
I'm going to just look at some of the questions online, and then I realize that we're not going to be able to address all of the questions, but I wanted to just make people aware that that Professor Devereaux has kindly agreed to stay on for about an hour after his lecture for some in-person discussion and Q&A, and that'll be in the pink room, which is just around the corner on this floor. So my apologies if we can't address everything. There's some comments online related to the importance of having kind of a unified REB, and just some acknowledgement that we continue to have challenges even at our university in that regard. There's a kind of a question around navigating kind of some of the legal issues around that, but I was going to maybe in closing ask you a question related to knowledge translation. So you're talking about clinical trials, and I've had an interest myself in the role and timing of surgery and spinal cord injury. We've had a number of trials that we've done. We have guidelines, but trying to actually change the way people manage patients and then trying to institute policy changes based on trials is quite challenging. And I wonder if you could maybe comment on that, because I saw that you had an arm in the ACT network related to knowledge translation.
Yeah, it's obviously it's a hugely important area. I want to be clear. It's not my area of expertise. My focus tends to be doing primary research, but I do work with a lot of people who are very engaged in that. Within ACT, we have specifically a knowledge mobilization committee, which focuses trying to how do we improve that translation. Again, the biggest thing that is very clear from the research that does exist is that if we get key opinion leaders involved in big clinical trials in as many diverse areas as possible, the uptake of research just ends up being a lot faster and a lot bigger because people are comfortable with it. And also, the clearer the results and the more profound the results, the more it's difficult for people just not to act on it. Still doesn't mean there's not times that people do it. There's also issues just convenience. Sometimes people don't want to do something because the truth is it's not that convenient for them. And so that's where it becomes, I think, a lot harder, and you need a lot more pushing, because like the work we've done, like with the issue of timing of surgery, it is, it's so hard to change. So hard, even like something as simple as giving TXA, there's challenges to make that happen on a daily basis. I'm now going to change the emergency room approach of someone showing up with potential hip fracture, the radiologist approach, the surgeon, anesthetist, all these different groups to say, we need to make this happen in 6 hours. Those are challenges, but they are doable. We've shown they're doable, but the point you're raising about moving from trials into everyday clinical practice, a lot of it comes down in the end, whether as a collective, we believe in something enough. People change things all the time. At times I'm always find it a miracle how some crazy changes happen so fast, even when there wasn't great evidence, but the group just decided this is what has to happen. So part of it is, I think, us getting more people engaged to believe, look, this is important enough. We need to do it as the right thing. And at times, myself included, fail and making people realize, hey, this is the right thing. That's lots of more work on knowledge mobilization.
Great. My apologies, Dr. Orser. I'm going to have to close it up, but maybe we can take this in the subsequent discussion. So we're out of time. We could probably go on for another hour online, but we need to close this out. We'll have a subsequent discussion offline. Professor Devereaux, on behalf of the University of Toronto, Department of Surgery, many thanks for a fantastic talk. Great discussion. Thank you for coming across. And on that note, I think we will close out our 2024 Ben Alman rounds. Thank you very much.
Sorry, guys.
Okay.
When I have, thank you very much.
Okay. So pink room around the corner, and Renata will lead the way and for some informal discussion.
Perfect.
Okay.
Thank you.